Assalamualaikum. Today we'll discuss a very important topic of airway management. It's very, very essential while doing resuscitation of trauma cases. Irrespective of your specialty, whatever you choose in your future career, this airway management, to know the basics and basic skills of airway management, this is very important for every one of you. So pay attention and you should get a lot of benefit. Before we proceed further, these are the objectives, learning objectives of this lecture. You should be able to enlist indications of airway management and then describe signs of airway. Very important. You should know the early signs and symptoms of the airway compromise, and so that you should react promptly because time is money in this case. Then you must understand various methods of airway management. What are the various tools and equipment available with you and how you're going to use it. This requires a little bit of skills which comes with little practice, but this can save lives. Then appraise various airway devices and adjuncts which are available. There are a variety of supraglottic devices. They can be used for emergency maintenance of airway, and this can save a lot of lives. Then last but not least, understand bag mask ventilation technique. This is the backbone of airway management. You should be able to do bag mask ventilation in compromised cases till the time help arrives. You should know how to handle the bag mask, how to hold the mask, how to ventilate these cases. So we'll discuss all these things one by one. And then this is a list of conditions where you do require, I've tried to summarize each and everything in this list, where you require airway assistance. Unconscious patient of low GCS, any unconscious patient due to any reason with GCS less than 8, they do require airway assistance and management. Then deeply sedated patient and anesthetized patient. These are the cases which you come across in operation theater, either at the time of recovery or in PACU, post-operational area, where these patients are kept for a certain period of time. They do require airway assistance in some form or the other. Then trauma cases, very important, especially related to this this field which we are discussing. Fracture cases of jaw, maxillofacial injuries, they do require airway management, and the response should be very quick. Then head injury cases, especially with low GCS, which we have already discussed as number one, they require airway management. Chest injury cases, again, very important. Flail chest due to multiple rib fractures, they do require airway ventilation and assistance. Extensive bruise or contusion in the chest, they do require airway assistance. Then cases of pneumothorax, again, very important to know it early and to do the remedy. Otherwise, we are going to lose these cases. Pneumothorax cases, they should be ventilated on priority basis. Then bilateral injury to the recurrent laryngeal nerve, this can happen in extensive thyroid surgery. They do require airway assistance and airway management. Any oral pathology could be in the form of growth, bleeding, any inflammation like quinsy, they can cause airway obstruction and they do require airway assistance. Then patient after drowning, obviously they inhale a lot of water, so they require ventilation on priority basis. Then patient requires CPR due to any reason. So airway management is integral part of CPR along with chest compression. All the cases which do require CPR due to various reasons, they require airway assistance. Foreign body in the upper airway can cause partial or complete obstruction. So emergency airway assistance is required in these cases. Similarly, cases of burns, especially inhalational and fume bouts of burn, they can cause a sudden edema of the upper airway and glottic edema that can cause airway obstruction. So prompt airway establishment may be in the form of tracheostomy or endotracheal intubation. In these cases, can avoid acute airway obstruction. Cases of respiratory failure due to any reason, for example, neuromuscular disorders, Classical example is myasthenia gravis in various forms of myopathies. These cases, due to hypoventilation, they do require airway assistance. Similarly, lung pathology, then chronic obstructive airway disease, lung fibrosis. These are the cases which require airway assistance at some form or the other. Then this is a list of, this is how you can prevent deaths, certain deaths, if you can recognize and if you can do the remedial measure in time. And failure to do this can cause certain deaths, and these are preventable. For example, we will discuss them in stepwise. Number one, failure to recognize the need for airway. Patient do require airway assistance, but we don't recognize that well in time, till the time patient goes into hypoxia, cerebral hypoxia. Second step is we do recognize the need for airway, but we are unable to establish an airway. So this comes with skill which you can learn in the skill lab on repeated attempts. You will be able to establish airway in emergency. Then third step is you have recognized the need for airway. You have tried to establish the airway, but the airway device which you have tried, it is incorrectly placed, and this is not recognized in time. For example, if you pass the endotracheal tube, it has gone into the esophagus and it goes unrecognized for 3-4 minutes. That can cause cerebral damage. So these are preventable. Then displacement of a previously placed airway. This is step 4. We have recognized the airway requirement. Then we have established the airway. And then we have correctly placed the airway. But due to change in posture of the patient or during shifting of the patient from one area to the other, maybe for radiodiagnostics, this airway can be displaced and it goes unnoticed. That can cause death, sudden death, if it is not recognized well in time. Then failure to recognize the need for ventilation. We have established the airway, but we do not ventilate the case properly. That can cause death if it is not recognized properly. Last but not the least, aspiration of gastric contents. Very, very important to prevent, especially in trauma cases, those who are full stomach cases. And as you know, the pH of acid content is 2.5. It's very, very acidic. And they say that 25 ml of 2.5 pH fluid, if it goes into the lungs, can cause 80% mortality. So it should be prevented. It should be recognized early and should be treated. Then in this, before we proceed further, we must know what are the various signs and symptoms of cerebral hypoxia. Early signs are this mental confusion. Patient is confused and disoriented, accompanied with drowsiness to begin with. Then tachypnea. Patients start developing rapid and shallow breathing. Then later on, it is accompanied with sweating and tachycardia, and patient become restless. From drowsiness, it becomes restless due to hypoxia. And then at a bit more later time, he developed peripheral cyanosis. So you need to recognize this signs and act accordingly and promptly. And once we go for airway management, it is divided into two parts. First part, we assess the airway, which require assistance. And then second part, we manage the airway, maintain the airway by various methods, which we'll discuss. So we'll discuss this in two parts. First part is assessment of airway. It's mainly sign and symptom, early signs and symptoms, which we have discussed in the previous slide also. Patient present with cyanosis, peripheral cyanosis, obstructive pattern of breathing due to some obstruction, foreign body in the upper airway, then trauma, which we have discussed, especially upper airway trauma, oral cavity, trauma in the oral cavity. They can cause airway obstruction. Then vomiting, present in unconscious cases, that can cause airway obstruction. So these are the various signs which we expect in these cases. And last but not the least is tongue fall. In all the unconscious patients, 99.9% cases, there is a tongue fall, tendency of tongue fall that causes airway obstruction. We need to do the remedy. So once we ensure that this patient requires airway management, then we go for it. First, we clear the airway, turn the victim on one side, and clear the airway in whatever way we can do, maybe with a piece of cloth or whatever. And this way, you can, and then at the same time, you try to remove the foreign body, vomitus, bleeding in the upper airway, and then do the airway maintenance. We can do this in two forms, either manual, where we don't have any equipment available. Or the second part is, if we have got the equipment, then we maintain the airway accordingly. And here, the airway maintenance, if we got the equipment, this is divided into two parts: emergency airway devices, which we'll discuss in detail in the subsequent slides, and definitive airway, if we require the ventilation for long term. For manual airway maintenance, the classical maneuver is head tilt and chin lift, and it is replaced by jaw thrust in case of cervical injury. So this is the head tilt and chin lift. On the left side of the slide, yes, there, this patient is unconscious, and see, the tongue has fallen back, and it has got the airway obstruction here. We need to replace it. You need to relieve it as early as possible. And once we come across with unconscious patient, the immediate remedy is this head tilt chin lift. With one hand, you place on the forehead of the patient and do the extension at the cervical cord, and then fix the forehead of the patient with one hand. And with the other hand, with the second hand, we lift the jaw upward by placing your fingers at the mantle of the mandible. By lifting the jaw upward toward the ceiling, the tongue, which is attached on the mandible, it is automatically lifted, or it is lifted upward along with the mandible, causing relief in the airway. So this is a basic classical maneuver which is used to relieve airway obstruction in unconscious patients. Okay. Now, head tilt chin lift, you cannot move the cervical spine in cases of cervical injury. So that maneuver is replaced by jaw thrust. In this case, the four fingers of the hand, they are fixed at the angle of jaw on either side, while with the thumb, you do the opening of the mouth. But at the same time, you make sure that there's no movement whatsoever at the cervical cord. So by lifting the jaw without moving the cervical cord, with this is called jaw thrust. And I told you already, this replaces the head tilt chin lift in cases of suspected cervical injury. Now, these are the various devices to begin with. These are emergency airway devices which are used without any assistance, because they remain above the level of vocal cord. Their lower end goes into the laryngopharynx, so they don't cross vocal cords, so they don't require any visual assistance while intubating, while maintaining the airway with these devices. Various devices I have enlisted here: the oropharyngeal airway, there's nasopharyngeal airway, there is laryngeal mask airway, then iGel and combi tube. These are the various type of emergency airway devices which can be used for airway maintenance in emergency. Oropharyngeal airway, which is also called Goodell's airway, it has got, due to color coding, it has got various sizes, just like cameras. It has got a concave surface which trap the falling tongue like this. Yeah. You place the oropharyngeal airway with concavity covering the falling back of the tongue, and the lower end of this Goodell's airway or oropharyngeal airway go into the laryngopharynx. And whatever you pass with the embo bag or in the proximal end, it bypassing the tongue, it goes into the laryngopharynx and cause the airway maintenance. If due to some pathology, you cannot go into the through the oropharyngeal airway, there is some bruise, some vomiting, or some infection in this area, or some foreign body. So you can use alternatively nasopharyngeal airway. Pass the nasopharyngeal airway through nostril. The lower end goes into the laryngopharynx, bypassing this area. This can be used in emergency. You can use two nostrils also. So another device quite effective is called LMA, laryngeal mask airway. Another supraglottic device. Lower end is cup shaped and it is inflatable, while the proximal end you can connect this with Mubeen or with ventilator. So this is how you place this on the left side of the slide, like this. Hold the LMA with the index finger and hold it like you are holding a pen while writing, just like that. And then you place the lower end of the LMA in a space between tongue and upper jaw, and slide it with the help of this index finger. Guide it and slide it with the help of this index finger like this. You slide the lower end of the LMA, passing over the hard pellet first, and then soft pellet, and then ultimately into the laryngopharynx like this. Once it goes into the laryngopharynx, then cuff is inflated, and then you connect this inflated through this cuff, and then you connect this with the ambu bag and ventilate the patient. From here, it goes from here into the through these vocal cords into the trachea. So this is a useful device in case of emergency airway maintenance. iGel is another airway. It is placed just like LMA, better tolerated, better placed, easy to place, and less chances of failure as compared to LMA. This can be used like the supraglottic airway device in emergency. It has got an additional port on the side of the main port, which can be used in this here. This can be used for suction. Here you can pass the suction tube melter here, and you can do the suction in this area just to clear the air. Combi tube is another airway, supraglottic airway device, can be used in emergency. It's a combination of two tubes like this. You can see in the slide. And there is a white tube. Yes. This is a white tube, and this is a blue tube. Two tubes. It has got two inflatable cuffs. The bigger one, laryngeal cuff, and then esophageal cuff, white cuff. And see these two tubes. White tube has got opening in the lower end. It is just like a conventional endotracheal tube, open at both ends. While the blue tube has got a closed opening at the lower end. While it has got multiple openings between the two cuffs, between these two cuffs. This is a blue tube. So what you do, you pass this combi tube blindly between the tongue and hard pellet, push it blindly, and it is likely 95% chances are that it will go into the esophagus like this. This is the most likely scenario because you are pushing it blindly without the help of laryngoscope. Once it goes into the into the esophagus, then you inflate both the cuff, laryngeal cuff as well as esophageal cuff, and then connect it with ambu bag, the blue tube, connect it with ambu bag, and push the air. The air which you are going to push through these small pores, it goes into the laryngopharynx. Like this. It cannot go up through this because there is a inflated cuff into the larynx. It cannot go into the esophagus because of this esophageal cuff. So this is emergency airway device, which is quite effective. Then in 5% cases, the chances are, if you're lucky enough, that once you're pushing blindly, it can go into the trachea directly. In that case, you just connect the white tube with ambu bag and start ventilating. So this white tube will act just like conventional endotracheal tube. Cricothyroidotomy, another emergency procedure which can be done if you are unable to maintain the airway in emergency due to your effort. There is a cricothyroid membrane present between the thyroid prominence, thyroid cartilage, and cricoid cartilage. You can puncture this cricothyroid membrane with a wide bore needle, wide bore cannula. Maybe 2 cannulas you can pass, and you can maintain the airway in emergency. So these are two definitive airways. Now, these are different from supraglottic devices, which we have discussed earlier. In these cases, the lower end of these devices, it goes and crosses the vocal cords. The cuffed area of this endotracheal tube and tracheostomy tube goes beyond the vocal cords, and it is inflated and fixed inside the trachea. So as we are passing these devices beyond vocal cord, so need to be passed under direct vision. You cannot push them blindly because they will go definitely into the wrong direction. So endotracheal tube is passed with the help of laryngoscope. You hold the laryngoscope with your left hand while stabilizing the head of the patient with the right hand. And then you go gradually downward and pushing the tongue toward the left side till the time you see epiglottis. And on the left side, you see this is the view which you are likely to see once you. This is the first anatomical structure, epiglottis, which you see once you lift this epiglottis upward. And this is this structure, vocal cords, which you see, these two vocal cords and trachea. And you can visualize the tracheal rings also. This is pink pale in color as compared to its surrounding area, which is pinkish in color. So you can easily identify that. And once you identify, you pass the endotracheal tube with your right hand under direct vision through these cords, like this. And once the cuffed portion crosses the vocal cords, then you inflate the cuff and fix the tube and start ventilating. This is long-term ventilation device where you think that this patient will require long-term ventilation. If due to some reason or the other endotracheal tube cannot pass, in that case tracheostomy tube it can be passed below the level of first cricoid cartilage tracheal ring. You can pass this and fix it. It requires a bit maintenance, but long term you can use it. Once you have established an airway, maybe emergency or definitive airway, then you do the ventilation either with mouth-to-mouth breathing or mouth-to-nose breathing or bag mask ventilation, or you can use portable ventilator. These are the various options with us. If you don't have any other device, this is you do in mouth-to-mouth breathing. Maintaining the head tilt and chin lift of the patient. You pinch the nose of the patient with your hand, which is stabilizing the head and doing the head tilt. You pinch the nose and take a deep breath. At the same time, lifting the jaw upward. Take a deep breath in, and through your mouth, you push the air in the oral cavity of the patient. It's mouth-to-mouth breathing. And once you're in the hospital setting, you have this device available in almost every area. Ambu bag along with face mask. This is how you you do the face ambu bag mask ventilation. See the first finger, the thumb and the index finger. By these, you hold the mask of the patient. This makes C, English letter C. And then with the rest 3 fingers, index finger, middle finger, the middle finger, ring finger, and index finger, you hold the jaw of the patient and lift the jaw of the patient. While with the second hand, you ventilate this. This is bag mask ventilation. Before the help arrives, if you know how to do this effective bag mask ventilation, you can save life. You maintain the head tilt chin lift position and just do bag mask ventilation. And after intubation, you can connect the patient with this portable ventilator. It has got an inflow air intake air comes through this area. It can be connected with oxygen also. And then through this area, it is connected with the patient through this tube, right? And this is a wireless control system by which you can do various settings in this portable ventilator. This is a device which can be used for emergency ventilation. You see, this is a portable ventilator in place, connected with the patient through an electrical tube, and then you feed the various mode of ventilation. This portable ventilator can be used during transportation of the patient from peripheral hospital to the base hospital also, and even within various areas of a hospital. This is quite effective, very effective way of ventilating the patient during shifting. Now, these are the modes of ventilation, various ventilation. These are the 4 primary modes of ventilation. They are all available in portable ventilator. While in advanced ventilators, ICU ventilators, there are advanced modes which we'll not discuss. But just to give you sort of introduction, first is controlled mandatory ventilation. This is also called IPPV, intermittent positive pressure ventilation. What you do in this case, patient is fully paralyzed and sedated. So you give fixed tidal volume with fixed rate, and you achieve fixed minute ventilation of the patient. In this case, patient is fully paralyzed. Now this is of 2 types. Either it is volume controlled, or it is volume controlled, or it is pressure controlled. In volume control, there is a chance of barotrauma, lung barotrauma. So this method mode is used in adults only, while this pressure control mode is used in case of small babies, small children, just to avoid the barotrauma. So, but in this case, patient is fully paralyzed. This is second mode. It's called synchronized intermittent mandatory ventilation. In this case, there is mechanical ventilation, which we have discussed in controlled ventilation also. So it gives a chance, it gives a pass to see that whether the patient is ventilating at its own or not. It gives way to the spontaneous breathing of the patient, and then it is supplemented with mechanical ventilation. Aim is to achieve that minute ventilation with this added mechanical ventilation. And this mode ensure that patient, although it's doing some sort of spontaneous ventilatory effort, but it is ineffective or inadequate. And this ventilator mode ensure that the patient at the end of 1 minute get proper minute ventilation. Again, in this case, patient is either fully or partially paralyzed and sedated. The third mode is pressure support ventilation. This is for spontaneously ventilated patient. Patient is not relaxed, not sedated, or not paralyzed. In this case, there is spontaneous breathing of the patient, which may be inadequate. Now, in this mode, the patient ventilate, and ventilator wait for this spontaneous ventilation, and then assist the patient with mechanical support and make the minute ventilation. These are the basic modes. While in advanced ventilation, there are some advanced ventilation modes also, which I told you they are present in ICU ventilation. With this, we finish with this airway device management and various devices. This is very important. We have got a skill station, and we are going to show you these equipments, how they are used in emergency. And as I told you in the beginning, it is very mandatory, it's very important to know how to maintain the airway management in emergency. Thank you very much.